Welcome, everyone. Thank you for joining us today on our first GTMRX Call for Member Feedback. My name is Katie Capps, co-founder and executive director of the Get the Medications Right Institute. I want to start by congratulating GTMRX on an important milestone. In just 18 months, we've grown to a robust membership base of 1,140 members, represented by 735 companies. The growth of the Institute has surpassed all expectations. That membership has been invited to offer input as part of a 4-part member feedback series. In total, we have over 450 people registered for the events. Each of these events will highlight steps to be taken for medication management reform, how we use diagnostics, how we integrate technology, how we pay, and how we practice. Now, in July, we released the Blueprint for Change, which is a robust report based on multi-stakeholder input and guidance for how to change the way medications are managed. It's our roadmap for reform. If you've not read it, you can access it through the Resource Center on the Get the Medications Right website. Before we get started, I want to thank our GTMRX Board of Directors. They offer strategic direction and support, and they serve as board sponsors for our work groups. I would also like to thank our executive members and strategic partners who support us through their leadership and funding. And finally, I'd like to thank the GTMRX staff. They do tremendous work. We are a small but mighty team, but it's a team that works very hard. So before we get started, I want to give you a little bit of housekeeping information. If you run into any technical problems during the presentation, contact Natalie Cromwell. Her contact information is listed here. All participants will remain muted throughout the event. So to ask questions, please use the chat box. General questions should be directed to everyone, and I will ask them during the Q&A period. As the moderator, I'll ask you the audience questions as well, and you should respond back by clicking everyone and noting the question number 1 or question number 2. How we use diagnostics to get the medications right matters, particularly when considering pharmacogenomics testing. In an effort to uproot today's trial and error approach to medication use, pharmacogenomics testing, accompanied by a team-based process of care, can help better evaluate medications to ensure that they're safe, appropriate, and indicated for patients. But to move this forward, physicians and pharmacists and other team members must understand their value and have the ability to interpret and make use of those tools during the CMM process. And consumers need to recognize their potential to personalize their care. Our Precision Medicine Workgroup and our Pharmacogenomics Payment and Policy Solutions Taskforce have been hard at work creating guidance and tools to expand access and adoption of these diagnostic solutions to inform comprehensive medication management and practice. And I want to thank both of these groups for their hard work. Presenting what they have been doing over the past several months is Jill Bates from VA's Phaser program and Brian Litton, Tabula Rasa Healthcare. They will both give brief updates on workgroup activities, and then I'll facilitate our member feedback section. I'll now turn it over to Jill.
Thank you so much, Katie. It's a pleasure to be here. Good afternoon to everyone in attendance. Thank you so much for joining. I am very honored to be able to share the hard work that our work group has gone through over the last 6 months with you, and I look forward to much feedback from you. There are several things that I would be interested in learning about, particularly from a diverse perspective such as the GTMRX membership. And so to orient you to our group is the Precision Medicine Enablement via Advanced Diagnostic Work Group. And you can see here that this group is co-chaired by myself and Brian Cavney with LabCorp. And what you see are our membership, and hopefully you can notice from our membership that we represent a diverse group of folks and professionals that are interested in pharmacogenomics. We represent a lot of different facets of the market and the community. And so as a result, we get diversity in perspective and a lot of nice thought and a lot of different contributions to move our work out of our work group forward. Next slide, please. And so what is our work? How have we moved forward? What have we done in the past 6 months? Well, our group has really been laying a lot of foundational groundwork for upcoming endeavors in the pharmacogenomics space. And specifically, we have been looking at pharmacogenomics as a tool, yes, but specifically looking at pharmacogenomics as a tool paired in the context of a delivery service system such as comprehensive medication management, to see how that tool of pharmacogenomics is paired with a service and how that influences care. Does it bring value? Does it change anything at all? How does that really impact the landscape when it comes to precision medicine and specifically pharmacogenomics? And so one of the things that we have done in our learning journey from this standpoint is we've collaborated with several stakeholders who've played key roles in the pharmacogenomics and CMM field. We've brought in some guest speakers, we've heard their perspectives, we've learned a lot of things from subject matter experts on this topic, and our group has really garnered a nice perspective on the pairing of pharmacogenomics as a tool with comprehensive medication management. And through this process, we've gained several insights. So the first thing that we really recognized was that we needed to socialize a few new perspectives and a few new ideas in the pharmacogenomics space. So specifically looking at the integration of pharmacogenomics with comprehensive medication management and how pairing those two things together can move us from precision medicine to personalized medicine. So it's an avenue with a service to help personalize care. So we really needed to socialize this concept. And then also looking at, where do different health sense systems and different practice models integrate pharmacogenomics, and how is that model? Is it a specialized pharmacogenomics model, or do we have more generalized standardization within the pharmacogenomics community where we have all different models of care integrating pharmacogenomics, so universal standardization, for example? One of the things that we talked a lot about was, okay, when we're looking at this and we're evaluating this data, what is the audience that we're evaluating the data in the context for? And who do we want to provide information to? And what we determined after evaluating the landscape is that we really wanted to speak to both payers and providers with regard to pharmacogenomics and in the context of comprehensive medication management. We did identify that even though this is a great idea and this is something that we think all health systems should be utilizing, this pair of pharmacogenomics with comprehensive medication management, there are gaps that do exist, and specifically with regard to pharmacogenomics resources and accessibility to pharmacogenomics itself, so testing and all the infrastructure needed to support that process. We also recognize that, while we do inherently realize pharmacogenomics does bring value to patient care, we need to clearly delineate that. So both clearly delineate that in concept, but then also be able to articulate that out loud as well. And then lastly, informatics is really an essential component of pharmacogenomics. And so we really need to make sure that that infrastructure is available to support. And one of the most important pieces to that is facilitating interoperability. Next slide, please. And so as we went through this learning journey and we gained some valuable insight, we took what we've learned and we compiled it together to create a tool that you can see a picture of here. So we developed this document entitled The Outcomes of Implementing and Integrating Pharmacogenomics within comprehensive medication management and team-based care, a review of the evidence on quality, access, and costs. And within this document, what you'll find is that it summarizes key findings from published literature that supports integration of pharmacogenomics within comprehensive medication management. So you may be asking yourself, how can this tool be used? Well, we believe that the utilization of the documentation and evidence of pharmacogenomics and comprehensive medication can support the following claims, and you can use it in a variety of ways to articulate these things. So things such as decreased costs, increased provider education, and increased patient satisfaction, as well as access to care and outcomes. Next slide, please. And of course, as we were going through this work and as we were creating that tool that we think will be very valuable, we did identify that, as I mentioned, there are some gaps. And so with gaps, there comes opportunities to be able to serve the community, to help our community serve our patients. And so what we hope to do moving forward and our goals to achieve are to evaluate existing gaps and barriers and to be able to itemize those things, yes. But mostly we want to create recommendations for solutions to integration of pharmacogenomics within comprehensive medication management. And because we gained so much insight as we put together that tool that we hope you'll find valuable that we just spoke about, we do want to provide more details with regard to our findings and our insight. And so we are currently working on writing up a summary of that work as a pharmacogenomics plus comprehensive medication management white paper. Next slide, please. And so I'd like to thank you for your attention. And with that, I will turn it over to Brian Litton. Brian?
Yeah, thank you very much, Jill. Great presentation. I'm Brian Litton from Tabula Rasa Healthcare. I am honored to co-lead the Pharmacogenomics Payment and Policy Task Force with Tom Kraus from ASHP. Truly everyone on the task force has been a co-lead, with every participant being deeply engaged and contributing a unique and important perspective in helping us together begin to tackle issues that have been challenging for us individually for a very long time. I'd like to thank individually my colleague Nikki Scovis for her leadership on the task force, as well as Bailey Larson and Julie England for the extra counsel and support they've both provided. And I think perhaps on behalf of every member of the Institute, I'd be remiss if I didn't call out Katie Capps and Izzy, two people who I don't think get enough recognition for the support that they provide to every one of us in carrying out the critical mission that they enable. Next slide. So over the past 6 months, our task force has worked to assess and understand better the landscape of payment and policies associated with pharmacogenomics and what actions we could take to facilitate and accelerate the adoption of pharmacogenomics in the context of comprehensive medication management. As part of this work, we looked at sources of available information, we scoured literature, we invited to speak before the task force and heard from a diverse group of stakeholders and thought leaders. And we focused in on the key challenges that have been in the way of PGx adoption. And we focused in on case studies across different segments of the market where there had been success as potential models to replicate and to scale. The work that we did gained a few key insights, including the following. Comprehensive medication management and pharmacogenomics should not be decoupled from one another. Comprehensive medication management supports the value proposition of pharmacogenomics, and likewise, pharmacogenomics enhances the value of comprehensive medication management. Thought leaders and policymakers must begin to think about pharmacogenomics as being coupled to comprehensive medication management programs and services, and it must be our role to educate them as such. Decision makers and thought leaders must be better informed about the successes realized when we do pair pharmacogenomics with comprehensive medication management through various use cases, and our task force has developed tool sets to help all of us do that work. To underscore the value proposition, PGx must also move beyond the reporting of single drug gene pairs to be able to inform medication decisions across an entire medication profile, again, which would happen appropriately within the context of comprehensive medication management. Next slide. So to help in these efforts, we too, like Jill's work group, have developed a set of tools. These tools that we've developed would be used to present to healthcare administrators, to healthcare thought leaders, to drive the adoption of pharmacogenomics, to educate stakeholders as to the definitions of pharmacogenomics, comprehensive medication management, to identify barriers and the relevance of pharmacogenomics and comprehensive medication management. They would highlight the unique benefits for employers as a marketing tool. To date, we've developed a number of these, and they will be released to the public in the near future. The intended audience for these, so for example, with respect to the health plan, we have a Medicare use case that would be used for health plans and health systems, and that would be used to educate decision makers and show the value of PGx and highlight the patient journey. The takeaways are improved outcomes and reduced medical expenditures. And we also have developed an employer use case where the intended audience would be employers, showing them beyond just the impact on outcomes and reduced unnecessary medical expenditures, the impact that these programs would have on employee wellness and presenteeism. Next slide. So as we move forward, opportunities for additional tools that we've highlighted are the following. We think that there's a great opportunity to develop a case study, which we have underway for the dual eligible market. We have a lot of information that we've aggregated coming from the PACE market, where programs of all-inclusive care for the elderly, for those who are not familiar. And we're pretty far along with that draft. We have a commercial case study that will draw upon work that we've contributed to the employer toolkit, and that's being produced as a part of the practice and care delivery transformation work group. We expect that to be completed soon. And we're also undergoing now a literature search to support a Medicaid case study. In conclusion, all of these tool sets we anticipate would be used by members of the Institute and beyond to be able to advocate for the use of pharmacogenomics in comprehensive medication management as one to be able to derive the maximum benefit of improving health outcomes and reducing unnecessary medical expenditures in the system. So with that, I'll end and turn the program back over to Katie, where we're happy to entertain your feedback, to learn from you, and to inform our process more. Thank you.
You're on mute.
Thank you, Brian and Jill. And I encourage those of you on the phone to please submit questions in the chat box. I also want to thank you both for your leadership and the leadership of your groups. The Institute is a volunteer-driven organization. We couldn't do it without you guys. So, Jill, I've got a question for you. The first question comes to you, and it's, what are some key points that a practice can take away from the Pharmacogenomics plus CMM evidence document that your group created? What are some of the key takeaways?
Key takeaways. So thank you, Katie. So I think that some of the key takeaways, really from my perspective, is the value of the addition of a service like comprehensive medication management. I think that we all recognize that pharmacogenomics in and of itself is a valuable tool, right? We know that pharmacogenomics can help us apply medication safety concepts and medication optimization strategies more precisely. But when you place that tool in the context of a service component, where you are using the tool which is just one piece of a complex puzzle, you can gain so much more value with regard to patient outcomes. And so I think that really what I garnered and took away from this exercise is that pharmacogenomics in and of itself is a valuable tool, yes, but pharmacogenomics paired with a clinical service such as comprehensive medication management is extremely valuable and can really up the ante when either of those things are used alone, because you're adding an additional variable and you're giving the service provider an additional tool to be able to help that patient and to be able to personalize and individualize a care plan for that patient.
And I think we found that out through some of the subject matter expert presentations that you have with your group, with groups like Teachers Retirement System of Kentucky and other organizations that actually paired those services and found that their results were better because of it. So,
yes, exactly.
So, Brian, from your standpoint, I'll ask this question of Bailey, who is part of your group. What are some specific policies needed to support pharmacogenomics testing within the full scope of CMM? Bailey, could you respond to that?
Sure, thanks, Katie. 1 second here. I'm trying to turn on my camera. So, as discussed, pharmacogenomics is just one tool that CMM and team-based care can utilize to get the medications right. Two specific examples of policies are having coverage of preemptive testing instead of single gene testing. This would allow the lab results to remain in the patient chart to be used for the remainder of their lifetime as comprehensive medication management continues. Another example for policy change is addressing the inconsistencies with the Medicare Administrative Contractors, or MACs, in different jurisdictions and the need for greater transparency. Coverage is inconsistent, so where in one state, if you're a Medicare beneficiary, your clinician may receive reimbursement for pharmacogenomic testing, but in other jurisdictions, maybe even one state away, the same coverage opportunities for Medicare patients don't exist. So this really limits the ability of patients and clinicians to access these services. Along those lines of requirements for reimbursement, there's efforts to increase the ability of properly trained and qualified providers to be properly reimbursed for their services. HHS recognizes the need for additional healthcare providers to be engaged in testing, and so policy should outline the reimbursement opportunities for them as well. These policies are needed to allow patients to access these healthcare services.
All right, thank you, Bailey. I want to remind the audience, if you would, there are questions that we have on the monitor that we would like you to respond to as we go through this. This serves as not only feedback to our speakers, but feedback for us as we move forward as well. So there are 3 questions listed, and if you'll respond back to that question with question 1, 2, or 3, we would be most appreciative because your input is extremely valuable to us. So the next question is for Nikki within Brian's group. Nikki, in what way does using pharmacogenomics testing improve the CMM process?
Yeah, thank you for the question, Katie. So when we think about the CMM process and how we go through each of the steps, PGx is one of the components that gets evaluated along the way. And so, like Jill talked about, that really helps us to address the precision versus personalized medicine question and bring in additional pieces of information to then, not only are we looking at whether medications are safe and effective, based on the literature and based on the clinical guidelines, but then we're taking it down to the individual patient's genetics to be able to then fine tune from those options what the most optimal option is. So it really helps us get into the best possible option. And then, as Jill mentioned, that impacts outcomes from there. So,
and this may be a premature question because I know you guys in the payment Pharmacogenomics Payment and Policy Solutions Taskforce have just begun gathering the evidence from that standpoint. But Brian Bailey or Nikki, could you respond to what you might envision the payment model for the CMM portion to be?
So I think Bailey described some of the policies that we're working toward in the payment model. And so Bailey, maybe you could talk more about specifically on the CMM side of things, some of the policies that would support payment.
Sure. So basically it's comes down to those Medicare administrative contractors, at least for the Medicare side, having transparency and consistency throughout all the jurisdictions. So that's a policy we are working to address, because right now some support way broader coverage and including preemptive testing, and that's definitely a step in the right direction, and there is some payment coming through, but there's still a lot of barriers, like who can receive the reimbursement for that. Sometimes it's only a psychiatrist and not even the primary care physician. So I think ideally a model would include reimbursement for trained and credentialed clinicians in a more broad scope for CMM, and consistency among all the jurisdictions for the Medicare coverage.
Yeah, and I would like to encourage those of you that are on the call with us today. These are some of the issues that will be discussed as both the Pharmacogenomics Payment and Policy Solution Workgroup moves forward, and as the Precision Medicine Workgroup moves forward as well. Jill, I'll give you the final question, and then we'll ask folks to maybe ask some additional questions before we close. But from your standpoint, what are some missing components found within the pharmacogenomics plus CMM literature? What are the gaps? Because as you mentioned, it's really important to look at the gaps as opportunities as we move forward.
Mm-hmm. Yeah, so, and I'm not necessarily sure that the gaps are in the literature as much as just kind of gaps in the system and community as a whole. So two of the things that we really looked at and came out of our evaluation process were gaps with regard to resources. And I think the resources are, both monetary resources to set up infrastructure to support pharmacogenomics. So there are, as I mentioned, informatics needs and other resources needed to support pharmacogenomics. And then even in looking right now at the chat, I'm seeing there's a lot of discussion on providers. And so I think that that is something else that we really need to recognize, is that, providers and pharmacists have varying levels of expertise when it comes to pharmacogenomics. And so you've got some providers that never were introduced to these concepts when they were in school. You've got some providers more recently when these concepts were part of the curriculum for pharmacists, for example, and their competencies for nurse practitioners, for physician assistants, for physicians themselves, for genetic counselors. So there's competencies in pharmacogenomics for all these different providers. That's just been a more recent development. And nevertheless, even though these competencies exist, there's not really been a universal way to integrate them. And so some people end up getting a lot of exposure and in-depth exposure, and some just get the surface level. So you've got varying level of expertise. And so I think that that those are some of the gaps. And and then accessibility to pharmacogenomics, I think, is a big gap. And really that is preventing us from getting the type of information in the literature that we need to really demonstrate clinical utility for pharmacogenomics. So some patients just do not have access to pharmacogenomics, both because of because of, lack of physical, tangible resources related to the testing itself, but then also related to the issue of the varying level of expertise from a provider standpoint that's not available to all patients right now. All patients do not have access to that. And so I think those are two significant barriers. And I hope that the work of our work group can really help to fill those gaps, and we can put out maybe some literature, some tools, or something that folks can use to take a look at that and really bring some viable solutions so that this tool, this diagnostic is something that patients have access to and is available.
So clearly, prescriber education, physician education, education to consumers is very important. And as this group moves forward, I would encourage you guys that are members that are interested in participating to let us know. There's going to be some important work, more important work coming out of both of these groups. Now, unfortunately, our time has come to an end. We could, I know, all speak all afternoon about this, but our time has come to an end. And on behalf of the Get the Medications Right Institute, I want to thank not only Jill for her leadership, but Brian and his co-leads for their leadership as well. I want to thank our presenters, Jill and Brian, and the rest of the Precision Medicine Enablement, the Advanced Diagnostics Workgroup, and the Pharmacogenomics Payment and Policy Solutions Taskforce for sharing your work with us. I'd also like to thank everyone who participated. The tools that Brian and Jill mentioned will be available to the general public after we go through our member feedback sessions. So if you have additional information, you were sent this tool before, if you registered for this event ahead of time, you were sent this tool before this event. So if you have additional comments or questions, please get that information to us. This is my email address, and we would love to hear from you, and we would love for you to get more involved. There'll also be a survey that you'll receive after today's session so we can get further input on the topics that we discussed today. I invite you to visit our website and download the Blueprint for Change if you've not done so already, calling for medication management reform. And as I mentioned, you should look for the forthcoming tools after we finish our member calls over the coming 2 weeks. Thank you for joining us today. Be well.